MRI scan of brain showed an approximately slightly greater than 3 cm contrast enhancing mass in the right frontal lobe with significant vasogenic edema and mass effect, and approximately 9 mm right to left midline shift, as well as subfalcine herniation. In the operating room, after induction of general anesthesia, his head was immobilized in a skull clamp, turned approximately 30 degrees away from the side of the approach, and angled for near orthogonal approach to the tumor, with gravity keeping the tumor along the axis of the surgical approach. Bone flap is elevated using side cutting drill. Dura is opened sharply. Computer navigation is used to confirm the precise location of the tumor. Bipolar cautery is used to create a small corticectomy through which the superficial edge of the tumor will be exposed. The general plan is to remove a relatively large tumor through a small corridor and therefore minimize damage to the brain. Through this small corticectomy, which is approximately half the size of the tumor, superficial pole of the tumor is exposed, and then using bipolar cautery, a small hole is created through which the tumor is going to be debulked. Okay, so here we are in the right frontal tumor, and decompress the tumor right from the core so it doesn't press on the brain too much. And at the same time, we can look and see we're almost at the edge of the tumor, so we don't need to go any further. So the key thing is to pour the tumor out without touching the brain, and then peel the capsule of the tumor and hold it within. That way we can take it out in one piece at the same time decompress it. So, and that's the almost the deep edge of the tumor. So we know that that's how far it can go deep. And now I'm going to core it further. Can I see the bipolar, please? And on, please. And we just take the volume of the tumor from the core out. That way, we have the advantage of both maintaining the capsule at the same time decompressing the tumor, so that we can fold the capsule in the cavity and pull it out without any damage to the frontal lobe, which is so sacred and critical to preserve. And that's what we are doing. Very careful bipolaring inside the tumor. So we are taking the tumor inside out first, and then we are going to fold the capsule within this cavity. And that way we minimize any damage to the frontal lobe. And we don't want to do too much irrigation here because we don't want to spread tumor cells around. And we can apply as much heat as we want from inside out on it, because we have a thick tumor wall around us right now. Just gently pour it out and making this big problem a small problem, and then carefully fold it out, bring it out. Minimal brain swelling, minimal violation of the frontal lobe. And that's the ticket for this surgery. Preserve the frontal lobe, which is everything. To me, absolutely eloquent cortex. So can I see the telco patty, please? I'm going to see if I can sneak between the border of the tumor and the brain without any pressure on the brain. That's take it. If there's any doubt, by plate. Looks good. I'm gonna pour the capsule, stay away from the brain, and advance the. Can you blend it on off this? Can I see the? Actually, I'll do it. Thank you. It has to be really wet. Okay. And on please. Hold the capsule. Gently advance this in. Now we're not pushing on the brain, but moving along the border of the capsule. And only apply heat to the tumor, not the brain. Very key here. And can I see another one, please? First one. We have created that empty space within the tumor, we can actually push the capsule in. Very nice and gently on the frontal lobe. And can I see the bipolar again, please? On, please. On. We want to make sure we stay in the tumor. Outside of the tumor. Tumor is further debulked to reduce its volume and in order to be able to deliver it out of this relative small corridor. Here we use ultrasonic aspirator to core out the tumor along its edges. So we are staying on the capsule of the tumor. By bipolarizing the capsule of the tumor, we kind of make it more distinct from the brain, stay away from transmitting heat to the brain itself, and also make sure that you're following the tumor all around its borders. And the cavity of the tumor has already been removed, so the capsule folds into the cavity really nicely. And you're staying exactly on the border between the tumor and normal brain, with only transmitting heat to the tumor and carefully separating it from the brain without any brain injury. And here's the capsule. Again, only by polarizing the tumor and the capsule of the tumor, making it somewhat harder and more distinct. And without any damage to the frontal lobe, very carefully. And making sure we follow it all through, all its borders. resected. We're going to remove the tumor in a few seconds, but patience is virtue here. And again, staying only on the tumor, not on the brain. Very carefully, making sure we don't leave anything around. That's the tumor and an empty cavity. And this tumor of approximately 3 centimeters size was removed through a brain corridor of nearly less than half its original size, minimizing frontal lobe injury. Sodium fluorescein guided microscopy as well as high magnification visualization was used to ensure there were no potential residual tumor. Having considered the false positive, small areas suspicious of being studded by tumor cells were treated with low current bipolar cautery. Postoperative MRI scan showed complete resection of the tumor with no injury to the surrounding neurovascular structures.